So some things I want to do real quickly now is to talk about what you can do. And Rhonda's going to help me out here. We basically see two avenues. We see working with the women directly. And so we actually are creating, we have created an intervention. We piloted it in West Michigan, just up the shore a little ways, and in Detroit, Ann Arbor area, and in Melbourne, Australia. And we're actually putting in grants, a very large $4 million proposal with colleagues in Australia and in the United Kingdom. And in the UK, they're at Edinburgh University and the National Society for the Protection of Cruelty to Children. So we're looking at the child welfare outcomes from intervening with survivor moms. So basically, the intervention is a psychoeducation program. It's 10 modules that the women study themselves and then speak to a tutor on the phone. And Rhonda was the West Michigan tutoring goddess. And so the idea is that they have information. They get a vocabulary to talk about their needs. They get emotional support from the tutor. And it's supposed to help them navigate the childbearing year. And basically, it's intended to be integrated primary mental health care, so it can happen right in the maternity care setting. We have a low literacy version, and we also now have an MP3 version that we were able to record in the studios at U of M. It draws from dialectical behavioral therapy. If any of you are working with moms with borderline personality disorder, it uses a lot of the same skills building so they can tolerate extreme affect, because you get a lot of extreme affect in pregnancy and birth and early parenting, and also to handle interpersonal reactivity a little bit better. And so basically, all I want to do here is run you down the topics. We sort of introduce them to trauma and childbearing, talk about PTSD. The soothing skills are PTSD symptom management, because we don't expect to cure it, because they're going to just get triggered all the time during pregnancy. It's not a good time to expect to cure, but helping them manage them so that they're less intense and don't last as long. Soothing intense emotions, improving interpersonal connecting, and all the skills training is around scenarios where they're having to deal with a doctor, nurse, or midwife, or having to deal with a new baby or family situations. There is a module about planning for labor and birth. The module about families of origin and social support was actually the one that the women had the most intense emotional reactions to. We measured subjective units of distress because we needed to verify that this was safe. And in that module, on a scale of 1 to 10, sometimes the SUD score was up around a 7. And that's emotional engagement, that's good. Women didn't drop out once they got to that module, they were okay. But that's where we talked about who is safe to babysit this baby, and talking about overt strategies. Are your parents, they're grandparents in society, we glorify grandparents, but are they really safe to babysit this baby? And so working with women on alternative strategies if that was not the case. We dealt with their worries about parenting, postpartum needs, and then the last module we wanted to end on a really good note, and it talks about attachment and post-traumatic growth. So these papers are published also. I won't belabor the statistics, but what I want you to see is that this blue line basically showed improvement on all 4 things that we measured, except for mood regulation. We just came to the conclusion that depression is just really challenging, and that women who have PTSD and depression need help for both things. But this is interpersonal reactivity, and that improved. PTSD symptom count definitely improved. And this one we felt really good about. It's anger expression, and we're working to prevent shaken baby or squeeze baby or baby that's scared by its mother's angry face. So that anger expression improved a lot. And all across the board, the baseline here is compared to women who did not get an intervention, but who had very similar levels of trauma and PTSD. What happened is this is the percent that the intervention group did better on these outcomes. So dissociating in labor, having that extreme reaction to the stress of labor, they did 15% better. They rated their labor experience better, so somehow the planning and preparation really helped them. Their perceptions of care from the nurse and obstetrician or midwife were better. Their PTSD symptoms were better postpartum. We didn't do so great on the depression, but they were still better than the women who got no intervention. And also they had less impaired bonding afterwards. But clearly, we're PTSD experts, and the things that they did better on are things that were real specific to PTSD. So we're happy to be taking on collaborators that have other expertise too. So now I want to introduce Rhonda to you, and she's going to tell you a little bit about what it was like tutoring with the women, and then talk about integrated primary mental health care.